So, welcome everyone. My name's Autumn. I am the project manager for the Canadian Coalition for Green Healthcare. And on behalf of the Coalition, Peach Health Ontario, and the Hamilton Family Health Green Initiative, I would like to welcome you to today's Cut the Carbon Beyond the OR session, Sustainable Respiratory Care and Inhaler Optimization. This webinar is being delivered as part of the Coalition's Preparing Canada's Healthcare Buildings for Net Zero project, made possible with investment from the Government of Canada's Low Carbon Economy Implementation Readiness Fund. Throughout the event, please use the chat function for any technical issues you may be experiencing. Use the Q&A function for any questions you have regarding the presentation, and our panelists will be answering questions at the end of the event today. We are also recording this webinar, and the recording will be sent to all registrants and available on our YouTube channel at a later time. Okay, I'll hand things off to June Kaminsky to share a territorial acknowledgement this morning for us.
Just turning the video here. Good morning, everyone. I'd like to welcome you to this circle and acknowledge the land that we are on, etc., and to encourage you to consider this. So we would like to begin by acknowledging that the land on which we gather, which is now known as Canada, is the traditional and ancestral territory of many First Nations, Inuit, and Métis peoples, and we express our gratitude and respect to these keepers of the land. And also to remind you that June is National Indigenous History Month, so it's a wonderful time for you to attend different events within your area to become more familiar with the First Nations and Métis people and perhaps Inuit people of where you live, and to celebrate their time-honored approach to protecting the land that we live on. I'll pass it back on to Autumn.
Thanks so much, June. Okay, so presenting today, we have Dr. Rebecca Douglas. Dr. Douglas is a community family physician in Hamilton, Ontario, with experience in comprehensive family medicine, long-term care, and episodic care. She is also an assistant clinical professor in the Department of Family Medicine at McMaster University. She has a particular interest in environmentally sustainable and climate-resilient healthcare. Since joining the Green Initiative at the Hamilton Family Health Team in 2022, she has supported efforts to integrate sustainability into primary care practice and education. Take it away, Rebecca.
Hi there. So thank you so much for joining us today for this Cut the Carbon event. Like Autumn mentioned, we're going to be talking about respiratory care, sustainability in respiratory care, and particularly optimizing inhaler treatment. So before we get started, I just want to acknowledge that this is an update to a presentation that was initiated and started a project that was started through the Hamilton Family Health Team back in 2022 by Tatiana Gakowski and Dr. Megan Davis. And that was actually when I first learned about the role of meter dose inhalers in climate and sustainability. And we obviously had a team working on this presentation, reviewers and others who helped prepare. We had a range of reviewers, both in family medicine, pharmacy, and also respirology with Dr. Duong. So thank you to everyone who contributed. So today what we're going to be doing is we're going to be starting by just doing an overview of climate and respiratory illness, and then looking at the inhalers themselves, but focusing mostly on the optimization of respiratory care and inhaler treatments, and then looking through some cases of how this plays out in the office setting. So if you're attending this event, you're probably already aware that climate change is both a health threat and opportunity. It has been noted by the Lancet Commission on Climate Change. And also that the healthcare system itself plays a significant role in producing emissions. 4.6% of Canada's emissions are from the healthcare system. So what we're focusing on today is the idea that meter dose inhalers actually have a disproportionate contribution to those emissions. So about 3% of overall healthcare emissions, but 13% of primary care are actually related to these small devices all alone. And we can see this was a study that was done in the UK, really getting granular detail of causes of carbon emissions in the healthcare system. And metered dose inhalers, though they're just one type of inhaler, make up a huge percentage of the carbon emissions. You can see it there compared. It's almost a third of what's produced by the entire pharmaceutical supply chain and production in the rest of the healthcare system. So just this one type of medication device has an outsized impact. In the Canadian context, we know that most of the inhalers prescribed in Canada are metered dose inhalers, so have that impact on the environment. And most of those metered dose inhalers are actually something called a short-acting beta agonist. So that's typically think of that as salbutamol or Ventolin. And these are actually often overused clinically in patients where their disease is not well controlled. So improving disease control can both lower the emissions and improve care for our patients. So this is where we get the idea of a co-benefit, improving health for our patients and reducing emissions and pollution for the planet. So when we started hearing about this back in 2022 or a little before that, it was really not something that was talked about all that much. But that has changed. So we're really starting to see more and more guidelines, societies recognizing this issue. So Choose Wisely, a lot of CME for family doctors is identifying the role inhalers play in climate sustainability, but also the thoracic guidelines, both in Canada and in the US, Europe as well, are also recognizing this issue. So they were really reaching consensus that metered dose inhalers are something we need to be paying attention to in respiratory care, both to optimize the care of our patients and to reduce emissions. So as an overview, climate change and sustainability is particularly relevant to our patients with respiratory conditions because they're particularly vulnerable. So when we think about what are some of the environmental effects of climate change, extreme heat, wildfires, air pollution, but also things like impacts on duration of seasons, water levels. These things are particularly impactful to patients who have breathing difficulty. These factors that can occur with climate change interact with our patients and their characteristics. So people can be particularly vulnerable to climate change and when they have pre-existing lung disease, but also when their respiratory system is more vulnerable because of extremes of age. In addition, if they are living in a remote location where they might have difficulty accessing emergency care, or be exposed to wildfires, if they have high pollution levels in their city, they're going to be more vulnerable to the impact of climate change on their health. When we add these factors together, so patient vulnerability and the effects of climate change, patients with asthma and COPD will have increased symptoms and exacerbations. This has triple effect. So it affects patients. There's cost to the patients in terms of their function, disability, and financial costs. There's cost to the system. So when patients have more breathing difficulty, they present to the emergency department, they're admitted to hospital. And there's cost to the environment, and particularly because the inhalers we use to treat these medications have a large greenhouse gas emission that drives up the environmental cost. As well, we know that patients just being admitted to hospital or visiting the emergency department has a significant impact as well. So the goal of the presentation today is actually to look at how we can minimize these impacts by helping our patients. One of the ways to do that is to reduce the patient's vulnerability. So many of us might be looking at things like social determinants of health, making sure patients have good access to healthcare, supports that they need. But today we'll focus more on the disease optimization, so making sure that our patients have accurate diagnosis and well-controlled disease according to current evidence and guidelines. When we improve the disease control in our patients, we can reduce the cost to the patient, the cost to the system, and the cost to the environment. And in doing so, we kind of optimize resilience for the system. So if our patient's disease is really well controlled and they encounter a heat event or wildfire event, they may not need to be admitted to hospital or may not need to visit the emergency department. So there are multiple gains when we improve control for our patients. A second area we're going to look at in this presentation is once our patient is optimized, there are things we can do beyond that that help to further reduce the environmental costs. And those would be optimizing the choice of inhaler for the patient. So often there's clinically equivalent inhaler medications, and the device, some of the devices are more impactful on the environment, as well as teaching patients to use and dispose of their inhalers correctly can further reduce the environmental impact. So now we'll go on to just talking about the devices themselves. So you may already be familiar with the different types of devices, but we'll highlight that there are three particular types of devices available in Canada. So the first is what we're talking about today, the metered dose inhaler. And this is what comes to mind when you think of someone with asthma. The child on the soccer field having trouble breathing, they're often going to pull out a Ventolin inhaler, which might look like this. That's a metered dose inhaler. In contrast to those, there are dry powder inhalers, which the patient breathes in deeply, and that helps the medication go into the lungs. So they don't require a propellant to get the medication to the patient. They use the patient's own inspiratory force. And also there are soft mist inhalers. These ones produce a little puff of medication on a spring-loaded device. These two devices do not include a propellant, whereas the MDI does. And that's why you see such a big difference in terms of the carbon equivalents for these devices. So the metered dose inhalers are around 20 times more carbon dioxide equivalents per device than the other two types of inhalers. These medications have an outsized impact in terms of climate. When we look at most medications, it's their life cycle, their production that causes their environmental footprint. However, with MDIs, 90 to 98% of that impact is actually due to the propellant they release when the device is activated. And they're the most common type of inhaler prescribed in Canada. The propellant is a hydrofluorocarbon, and there's two that are in most inhalers most of the MDI inhalers in Canada. And with this slide, you can see when we put this into the carbon equivalents into what that might look like in a car journey, you can see the big difference. So a metered dose inhaler would be equivalent to about 120 kilometer car journey, whereas one of the other inhalers, these DPIs or dry powder inhalers or soft mist inhalers, only about a 2 to 4 kilometer journey. So why are we still prescribing them if they're so hard on the environment and there's different options available? Well, it's not quite that simple. Certain populations do need these metered dose inhalers, and they're kind of the most versatile device. So for patients who have coordination difficulty, preschoolers who maybe can't coordinate pressing on the device and breathing in it appropriately, these devices can be paired with a spacer, which allows the patient to breathe normally and get good medication. Also, if someone's having an acute asthma exacerbation in the emerge, they can't breathe in deeply for some of the other asthma dry powder devices, and so they require these types of devices. So there's an ongoing role for these types of devices. They are needed for patients who have difficulty with coordination and can't take a deep breath at the time that they need their medication. As we mentioned, there is the drawback of them having a very high environmental impact. Also, these devices don't have a counter. So when patients are taking their inhaler, sometimes it could be empty and they're not aware. They don't know how much is left. Contrast that with the dry powder inhaler. So the dry powder inhaler is a good option for many patients. It actually can be easier to use in many ways, and patients don't need to use that aero chambered plastic device that they don't typically carry with them anyways. They can get better deposition in the lungs just using the dry powder inhaler. These dry powder inhalers do typically have a counter, so your patient can tell how much is left. And one of the great advantages is that they're often available in combination. So both the controller and the reliever medication can be in one device. So we see this particularly, and we're going to come back to it with asthma control, with ICS formoterol devices that have both a steroid and a reliever long-acting beta agonist in the medication. There are some caveats though. We can't use dry powder inhalers for preschoolers or those who can't breathe in deeply, like I mentioned, and they can't be used in patients with milk protein allergy. The third option, the soft mist inhalers, are almost the ideal device. You don't need to breathe in deeply. They create this mist of medication. The issue with these is they're available in most of the medications for COPD are available as soft mist inhalers. A lot of the asthma medications are not. And the coverage can be an issue for these patients, particularly the short-acting beta agonists, that reliever medication that our asthma patients use and our COPD patients use is not available in this format. So it's a great format, really good for COPD control, but not an option for some of our patients. So I hope that gives you a bit of an overview of the different types of devices, with the recognizing that the meter dose inhaler is the one that really has the big carbon impact. So we're going to look now, and we've spent the bulk of our time just looking at optimizing respiratory care and inhaler choice for patients, because this is where we really see the opportunity for impact. So like we mentioned, when we optimize care, our patients benefit, the environment benefits, and the system benefits. So we have to see, like, where are these meter dose inhalers coming from? Where is the key area where they are being used? And this was a really interesting study that was published in 2024. And what it showed was that the big driver for prescriptions of meter dose inhalers was in patients that have very poorly controlled disease. So poor control in asthma patients in the UK had 8 times higher per patient carbon emissions. So poor patient control was associated with high carbon output. They did a survey of 28 countries as well, and what they found was almost all of the meter dose inhalers and the emissions that came from asthma care were from those rescue medications, that blue standard Ventolin that you see. And what was really interesting was 90% of those prescriptions went to patients who were already drastically overusing their reliever medication, so basically had very poor control. So what this basically tells us is that the driver of meter dose inhaler prescriptions in many countries, and also probably in Canada, where we know it is in Canada, is excessive use of rescue inhalers, relievers, and that by improving patient symptom control and patient disease control, we can reduce carbon emissions as well. So a co-benefit. In Canada, about 900,000 salbutamol, blue MDI inhalers, relievers, are distributed every month. And this accounts for 71% of all the inhalers in Canada. It doesn't need to be this way. So compared to other countries, Canada is actually on par with many other countries in the world, but there are countries that predominantly use dry powder inhalers and soft mist inhalers and have very good respiratory outcomes and respiratory care. So Sweden and Finland would be examples of this situation. There's, as at a national level, they have moved towards dry powder inhalers as their predominant inhaler that they prescribe. So how do we get to there from where we are right now? So there are certain significant challenges in optimizing respiratory care. So I'm just going to highlight some of the points that we might want to focus on in terms of trying to address this issue. The first point is making sure patients have the correct diagnosis. So in Canada, about 30% of patients with a COPD or an asthma diagnosis have never had spirometry. Spirometry is really the only way to confirm diagnosis, and there are barriers to accessing this for patients. It's not available in all communities. When we look at how to improve this, there is some evidence that family doctors, if with the correct training and equipment, can provide this service. Often it's referred to hospitals, but expanding this, especially in more rural communities, may be a way to improve our diagnosis. If a patient has the incorrect diagnosis, they can be using their reliever excessively and missing out on the correct treatment. The second step, when we know the diagnosis is correct, is to make sure the patient is receiving evidence-based, guideline-driven care. So I've highlighted here the two global guidelines that are most recent for both asthma and COPD, because this is a shift. So in the past, if we go back 10, 15 years, there were a group of patients where it was recommended, that they just use their reliever medication as needed. And for many patients, particularly in the walk-in clinic setting or family practice, they're still on this regimen. So they're just on their Ventolin alone. They might not see their regular provider because it's an episodic illness, and they remain on Ventolin alone. So highlighting this is important because the recent data has basically shown that uncontrolled asthma not treated with controller anti-inflammatory medication leads to increased risk of exacerbations, worsening lung function, and increased risk of death due to asthma. So patients really should not be on just a reliever medication, but should be on a controller as well. And the preferred controller is actually a combination that has both the reliever and controller together, so that whenever patients have symptoms and relieve them with their reliever, they're also getting the controller. When those two medications are split up, patients get quick relief from their reliever, and they'll often neglect to take their controller, which is important for disease management. Fortunately, the ICS formoterol, which is the preferred treatment, is available as a dry powder inhaler. So that's often an effective treatment for patients who are overusing their meter dose inhaler reliever at the moment. Similarly, the guidelines for COPD management have moved away from relying on short-acting relievers. Those are still an option, but we want to be using long-acting relievers to control disease so that patients are not overly relying on their short-acting medication. And I've included here, sorry, the bottom is a little cut off, just a great, very quick summary of a way to take action on this issue in practice or in the clinical setting. And that's looking at the refills that patients get when they're requesting their short-acting reliever medications. When I was training, it was very common to write, Ventolin 10 refills. We may want to rethink that. If a patient's using too many of their relievers, they really should be seen and reassessed in clinic. So that can be a red flag. And it's an important thing to think about, because more than 2 Ventolin inhalers or salbutamol short-acting reliever medication inhalers a year is actually associated with increased exacerbations, hospitalizations, and death. So if you've got a patient that's refilling 6 bronchodilators a year, they're at increased risk. And one of the shifts that we've tried to make where I work is to reduce that number of refills that are given to the patient so that this gets reviewed more often. This slide sort of refers back to what I was talking about, with the emphasis being on both controlling and relieving the medication at the same time. So the 2-in-1 device. And that's the preferred treatment for asthma in the most recent 2025 guidelines for patients over 12. Because this long-term reduces the risk of exacerbations. And from an environmental standpoint, most patients are going to be using a DPI for this preferred therapy. So there's 2 ways in which this is an environmental benefit. So both for better disease control, but also for having the patient on the preferred low-carbon device. Similarly, in COPD, we want to control the device and not have the patient relying on their short-acting reliever medication. Studies have also shown that excessive use of the reliever in COPD is a marker for poor disease control and increased risk. So again, I just want to clarify, it's not that patients don't need relievers. They do absolutely need relievers. They are life-saving medications when patients are having exacerbations. But using too much of your reliever means you need to see your doctor because your disease is not controlled and you need more intensive therapy. So with COPD, this is from the most recent Canadian Thoracic Society guidelines. You can see that even for patients with low burden of disease, we are looking at long-acting medications right from the get-go with the short-acting relievers just as needed medication. And if they're needing a lot of their short-acting reliever, they're having more symptoms, they really need to be stepped up in terms of their controller therapy. So optimizing the disease control is what we've talked about so far. A few more words just on optimizing the choice of inhaler when there are options. So which device is best for the patient? Like I mentioned, the one that gives the best control. So often that's going to be a combination medication that they can use easily. But in some patients, like we looked at when we were talking about the different devices, some patients are going to need a metered dose inhaler because they can't effectively use one of the soft mist or dry powder inhalers. They can't afford it, or some other reason that it's not a good fit for them. So the device that's the best is the one that's effective for your patient and gives them the best control. What device is the best for the planet? Same thing, the one that the patient's going to use and give them the best control. Now, if everything else is equal, choosing a dry powder inhaler or a soft mist inhaler is going to be the best alternative environmentally. And this has been supported by numerous societies and guidelines that we should be choosing the device accurate to the patient's needs. And then if two of the societies highlighted that if all else is equal, choosing a dry powder inhaler is probably the way to go. I bring this slide up. This was done by Dr. Sargent's group looking at the different interventions that can be done in primary care to reduce carbon emissions. And choosing dry powder inhalers over metered dose inhalers was seen as a game changer. So very significant impact in terms of the amount of carbon emissions from a practice. Initially, there is some effort on the clinician's part and more time to educate patients. If patients are deciding to switch from a metered dose inhaler to a dry powder inhaler. But often that's clinically the best thing for the patient, and long-term, if it gives better disease control, it's actually going to reduce workload for the clinician. So it might become a low-hanging fruit over time. What do patients think? So there have been some surveys that looked at whether patients think they would want to know about the carbon impact of their inhalers. And both in a study in BC and one in the UK, this was something that patients felt was important to know about. And if they could get good control with an equivalent inhaler, they may consider switching. So definitely something we can bring up. It's very reasonable for us to bring this issue up to our patients and give them an informed choice. When switching inhalers, fortunately in the last few years, there's been a number of groups that have put out aids for clinicians who want to switch patients, or patients who want to switch from maybe a carbon intensive inhaler to a lower one. Just a couple key things to keep in mind. One is when you are switching patients, prioritize those patients where you're quite confident you're going to be improving their control. Maybe the ones that are currently poor controlled and overusing their Ventolin inhalers, switching them to a combined track 1 treatment, evidence-based treatment is going to give you a lot of co-benefit for both the patient and the environment. If you're switching for the patient, they're well controlled on their MDIs, but the patient wants to switch, or you're thinking, I would like to switch a lot of my patients, make sure that's an informed decision. There is always a risk if the patient doesn't really understand how to use the new device, or they don't like the new device, it could affect their control if it affects their compliance. Patients that are switched definitely need education. They need to be observed using the new device. They need follow-up, and importantly, they need a new action plan, which is always a struggle. So many patients do not have an action plan, and they should for both asthma and COPD. So resources on this slide, there's ones from the UK, and like I mentioned, there's ones from lungtoolkit.com, which is affiliated with I believe a group in Toronto, and the Canadian Thoracic Society has also reviewed this document to help with that decision in switching safely if you decide to go that route. All right, so that's sort of the overview of the information. To kind of get a better sense of how this is applied clinically, we're going to look at a few cases. And hopefully with those cases, I can also give you some tools that might be helpful in implementing in your practice, or in your, suggesting to those you work with who may work in primary care. So this is a really common case. So this is Michael. So Michael's a 32-year-old man who presents to a family practice. He's had some cold recently with wheezing and shortness of breath. He feels a bit tight in his chest, but no history of asthma or allergies or respiratory conditions. His exam is essentially normal, except that he's got a little bit of a wheeze. So I'm not sure how many clinicians are in the audience, but very commonly we'll see this patient and they've had a cough for a while. They really have the expectation that you're going to do something to help their cough. So does this patient need an inhaler? You can think about that for a minute. So if we think this patient just has acute bronchitis or a cough related to respiratory tract infection, bronchodilators are actually not recommended routinely, even with a bit of wheeze. So if the patient doesn't have known asthma, doesn't really suggest an asthma history, there's really only modest benefit in reducing the duration of that cough. Bigger benefit probably to educating your patient about the expected duration. So adults expect their cough to last 5 to 7 days after a cold. The reality is it lasts about 3 weeks. So knowing that, supporting them with over-the-counter measures, fluids, humidity, and just understanding that this is going to take a while to resolve may be sufficient. Using the viral prescription pad may be a really good way to go. Don't necessarily need to prescribe an inhaler. However, sometimes, if the wheeze is significant or a patient had benefit in the past, person still may choose to prescribe it. So, no, doesn't really need an inhaler, but if you choose to prescribe one, which one should you use? Does this patient does he need an MDI, or could he use a different inhaler? So just to remind ourselves, dry powdered inhalers cannot be used by certain groups. Preschoolers, elderly patients who maybe are too frail to breathe in deeply, or those who cannot coordinate use of a DPI. They can use a metered dose inhaler with a aero chamber, or patients with a milk protein allergy. How do you know if your patient can breathe in deeply enough? This is one of those practice tools that you can use. So you can just watch the patient and see if they can have a deep, forceful inspiration. That's clinically valid. But if it's uncertain, maybe they have advanced COPD or they are quite frail, you can actually purchase the in-check dial device, which comes with replaceable mouthpieces and can be used to measure inspiratory force and see if your patient is able to use a dry powder inhaler. This can be if you're switching, like if your go-to medication has always been the Ventolin, there's another point of care tool that can be helpful for switching over to choosing a dry powder inhaler, and that's inhalerguide.ca. So this was produced by Cascades, and it's a website that can be linked from your phone or your desktop that helps you choose a reliever that might have a lower carbon footprint. And it's wonderful in that you can select which province you're in. It'll tell you which devices are covered under your province's plan as well. So when you go into the guide, if you select the inhaler, it will bring up information, the dosing, there's a how to use the inhaler, the cost. So, if it's not right at the front of your mind which inhaler to use, this is a really excellent resource. So when we think about our patient, Michael, he doesn't really have any of those contraindications to using a dry powder inhaler. Bricanol would be a good option if you do want to treat him, and you can teach him how to use it with the device. If your patient does need a metered dose inhaler, say they're a child, like a young child, if you simply choose the Tiva salbutamol or Aeromir, it's a different formulation, a lower volume inhaler, which actually still has significantly lower carbon emissions than the regular Ventolin. Once you prescribe your inhaler, it's very important that your patient knows how, so you can teach them yourself, like demonstrate or use a sample or in the office. Alternatively, Canadian Health Association has a website with many videos that can be used. You may also want to use team-based care, so referring the patient to an educator to really make sure they get the teaching about how to use their device effectively, so they're not wasting medication and so they maintain good disease control. And then once you prescribe their inhaler, if they're using a metered dose inhaler, make sure they've got this aero chamber. They get much better control with fewer puffs. And if they return their inhaler to a pharmacy for incineration, that also reduces the carbon footprint of the inhaler. So in Michael's case, we decided to prescribe a reliever for him, but he was able to use a DPI. So just following up on him, he comes back 3 years later, sees you again, and this time's had 2 more bouts of wheezing, has some seasonal allergies, and you're really suspicious for asthma. So you send him for spirometry to confirm the diagnosis, and he has asthma. What's your approach now? This is where we want to optimize his treatment. So right now he's got his Ventolin inhaler that he maybe borrowed from a child, one of his children, that's not uncommon. He's not getting any controller medication. So even if he was given a prescription for a metered dose inhaler controller, such as Flovent, he may not be using it because less than half of patients fill their maintenance inhaler medication. So the best way to make sure he's got good disease control is to make sure he's using just one inhaler, and that's the combined ICS formoterol inhaler that's recommended in the GINA guidelines. So if we switch him from his Ventolin to his ICS formoterol device, he will be on the first track of the recommended evidence-based treatment for asthma control. We need to make sure he's educated and that he has follow-up, that it's controlling disease well. And we always need to give an action plan, especially when we're giving a new inhaler, so that he knows how to treat if his symptoms worsen. I really want to highlight this action plan from RX Files is free to download, and they have it for many different inhaler options. So I would strongly suggest if you don't have a ready to go action plan, take a look at those. And then once again, teach him how to dispose of his device. So moving on to our second case, this is a COPD case. So Susan's 64, she has COPD. She's coming in with a 2-week history of shortness of breath and cough. She's been using her controller medication, which is Spiriva, which is a long-acting muscarinic, but noticing that she's using more and more of her reliever, short-acting reliever, her salbutamol. Her exam she looks fairly well, but she does have some decreased breath sounds and some wheezing. How do we want to approach her? So she's already had her diagnosis confirmed, but she's using more than 2 canisters per year, so she does not have optimal disease control. If she's already on her LAMA, we're going to want to step up her therapy. and move her to a lama-laba so that she's well controlled and not needing excessive short-acting relievers to control her symptoms. We do want to think about whether she can use this device. So for patients with COPD, they may have weak inspiratory effort, and we only want to switch them to something like a dry powder inhaler if they can produce enough effort. So you could use, again, the in-check dial device, or you may want to use something like a soft mist inhaler, which is also a low carbon device and doesn't rely on inspiratory drive. So that's just an overview of the process to take to both optimize patients and to think about choosing devices that are going to support their health, but also the sustainability of the environment. So just to summarize, if you haven't thought about this issue before as a clinician, it can be a bit overwhelming. So just taking one small step is generally the place to start. And since we know that the largest driver of both a large marker for poor disease control is salbutamol overuse, one of the simplest things you can do is reducing the number of devices that you prescribe and refills you prescribe to patients, so that they come back to your attention when they're using their relievers excessively, and you can reevaluate and improve their control by optimizing therapy. I've included some of the references here for like the inhaler guide and the videos. Another easy step in your EMR would be to add, when you really do need to use an MDI reliever, the Tiva salbutamol inhaler, which is prescribed and used exactly the same way as general salbutamol, but has a lower carbon footprint. Other easy things to do would be to post some of those decision aids around inhalers in your office, so if patients have an interest, they can bring it up to you. So to summarize, the metered dose inhalers are a significant source of carbon emissions, and they're often prescribed in patients where there's no plan made to confirm this diagnosis of asthma and no spirometry is done. Number two, overuse of short-acting reliever medications is a marker for poor control and should trigger reassessment for patients. So if they're using more than 2 or 3 inhalers a year of the relievers, there's a good chance they could benefit from optimization. The best way to reduce carbon emissions is through optimal individualized respiratory care, and choosing dry powder inhalers or soft mist inhalers when there's no compelling reason or clinical reason to stick with a metered dose inhaler is a good way to reduce the emissions. In addition, teaching patients to effectively use their inhalers, use an aero chamber if they're using MDI, and dispose of them properly will also reduce impact for the environment. And here are some references that you may want to take a look at. So thank you for staying with that. I think we'll go to questions now.
Thank you so much, Rebecca. So yeah, we'll open it up to questions. We do have one question in the chat to start us off. So the question is, what type of interventions have you seen / do you think would be most useful to mobilize this knowledge within a hospital and shift behaviors?
So I don't work in the hospital setting with inhalers, but I do know from some of my colleagues, it's typically so in the emergency department, metered dose inhalers are the rule, and that's because when patients are having a severe asthma or COPD exacerbation, they can't really breathe in deeply enough. So DPIs may not be an option. There are some studies starting to look at whether that in-check dial device can be used in eMERGE and for hospitalized patients. So Dr. Duong, who reviewed this presentation, is looking at that. So that may be one route to go. Another thing that has been effective is working with your infection control for reusing metered dose inhalers that have, so for reusing them when it's following proper infection control procedures. So initially it was use it for 3 puffs and then for 3 sessions and then it gets thrown out. But there may be a role for reusing that. And I believe at Sick Kids, there's some work being done on protocols to safely do that.
Awesome, thank you. And Michael, if you have any other questions to follow up on that, please do let us know. So while we wait for a couple more questions to come in, I do have one for you, Rebecca. So I was wondering, do you mind chatting a little bit about the barriers and facilitators of integrating this initiative into like a clinical context from your experience or the experience of your colleagues? Like, given all of these steps, what are some of the practical challenges that you've seen be a barrier or a facilitator?
Yeah, so I definitely want to acknowledge that it's not an easy shift. So I think most clinicians are very comfortable with meter dose inhalers, and we see them work quickly when we give them to our patients, and our patients like them. So what I would say that the barrier is it takes a lot of convincing if you're trying to switch patients from one inhaler to another. And that depends on how motivated the clinician is and how much time you have to do that. Facilitators, though, I think are the taking small steps. So keeping it in your mind and taking small steps. So simple things would be sort of the cases I came up with. So like in the patient presenting with a cold, trying to not prescribe a meter dose inhaler to help with their cough or their wheeze when they don't have a diagnosis of asthma or COPD. And if you really are going to prescribe a reliever, going with a DPI, because this patient's not at risk of having a severe exacerbation. They really don't need a meter dose inhaler. Similarly, when you're seeing patients that are new or maybe just on a Ventolin inhaler for asthma, really looking at the guidelines and switching them to something like formoterol ICS can simplify their regimen, and it's a win-win for the patient. So the patient's going to have better control. They're going to come in and see you less often, and they're not going to be overusing their Ventolin. Another facilitator is when patients, they're really committed to their meter dose inhaler. They like the way it feels when they take it. Often what I'll do is I'll say, if the Symbicort doesn't work when you take it, the ICS formoterol doesn't work, here's a Ventolin, you can use it. You've got it there, we're not taking it away, but I really want you to have good disease control. So have it there for emergencies, but when you try your Symbicort first. And that's a pretty effective approach for patients.
Awesome. Thank you so much.
Yeah. If anyone has experience and would be willing to share experiences or challenges, that would also be great. I'm not sure if anyone here has that in their practice.
Absolutely. And we also have one more question. So you mentioned how bringing an inhaler to pharmacy for disposal and incineration is better for the environment. I've heard more about the recycling programs. What are your thoughts on them? Any concern with disposing MDIs that are not empty?
So this is mostly for communities. So I don't know in the hospital setting. I think that's where you're thinking about the recycling. I'm not quite sure with the recycling. It's actually when there is some of that propellant left that the incineration is useful in reducing the carbon footprint. So that would be the situation that you do get a reduction. That's opposed to the patient just throwing it into the garbage. So that's where we're looking for patients to bring it back to the pharmacy. If you are close to a pharmacy, though, you may want to check on the status of whether they actually have a program and are willing to accept those inhalers before you tell the patient to do that.
Yeah, for sure. I have another question, and it's more directed towards residents. What kind of recommendation would you give to residents who are still in med school and are just learning about all of this? Like anything that should be integrated into the curriculum regarding this? How do you see this going forward in the future to help improve the impact?
So I think, like clinically, the residents that I've spoken with, and medical students I've spoken with recently, actually have a really good awareness of this. Although I think they may actually be the ones highlighting this issue to their preceptors. So I would really encourage them to do that because I think this, like I was saying, like I first heard about this in 2022 when I was listening to Dr. Davis's presentation. So this is a fairly new issue, and to trickle out into the community, family doctors have tons of different areas to stay up to date on. If they can bring this to their supervisors and even use it as a quality improvement project, that would be a great way to spread the word and improve care for both patients and the environment.
Amazing. That's great. Okay, let's do a last call for questions. Is there anyone else who has a question? Feel free to type it in the Q&A chat or just the webinar chat. Sorry. Okay, I'll pass it on to June and Autumn. Sorry.
Thanks, Lisa, and thanks, Rebecca, so much. And thank you to everyone who joined us today. Like I mentioned at the start of the call, this is recorded, and we will be sending along the slide deck and the webinar recording at a later time. Please share with your colleagues. And I would also like to ask everyone to participate in our post-webinar exit survey. This is really important for our project and all of our key performance indicators and all that good stuff. It takes just a minute. I just put the link in the chat. I'll be following up via email as well. So again, really appreciate your time doing that and your time here today. Have a great weekend, everyone.
Thanks so much.